HS2, Adventist Heart Study 2, Health Study 2, and then from Oxford there is EPIC study. And all those actually shows that it can reduce the all-cause mortality as well as cancer risk. So from that point of view, vegetarian diet is excellent. This is the summary table of keto, intermittent fasting and plant-based. I have already covered this. You already know that there are some concerns with keto diet, but if you are to reduce your body fat rapidly, that's the best bet, and one can always switch from one diet plan to other. So that's the best part of it. There is no need, because you can always individualize. Thank you.
Thank you so much, Dr. Rahul, and for finishing well in time. That was very informative, and I'm sure there will be questions at the end of the session. I now call Dr. Ajoy Biswas. Is he here?
No, sorry.
No. So I'll request Dr. Emmett Sanwarwala to come and speak on the usefulness of carbohydrate counting in tackling glycemic variability in type 2 diabetes and variants. Dr. Sanwarwala, President of DRWA.
Thank you. A very good morning to all of you. We've jumped to this topic before the others, but I'll be talking basically on this carbohydrate counting and how we can use it to tackle the glycemic variability in type 2 and the different variants. Basically, what is it? It is a meal planning tool used in diabetes management to help optimize blood sugar control. And remember, it can be used independent of the insulin therapy. My slides don't have very much picture or representations because I got this talk at the last moment, so I just managed to piece it all together for your benefit. And what is basic carbohydrate counting? We have two types, basic and advanced. So the basic is basically a structured approach. The emphasis is it is a structured approach. That means the amount and timing of carbohydrate consumed is fixed, which is to be consumed for the entire day and will be divided between the different meals and snacks throughout the day. And where is it indicated? For those who desire an approach to eating, we should promote weight loss. Those who want to control their blood sugar with just diet and exercise alone, patient on split mixed insulin regime, and those on a fixed rapid-acting insulin dose with meals. And in the advanced carbohydrate counting, it involves basically matching of how much carbohydrate you're eating with the dose of insulin. And this allows you a freedom of choice. And this is based on basically the insulin-carbohydrate ratio. But with the freedom, it doesn't mean that, okay, you can go and have a sumptuous meal in a wedding feast, and then you just take a double dose of insulin at night. No, basically we have to promote healthy eating so that in the long term we can maintain a better glycemic control and reduce the glycemic variability. And where is it indicated? Basically, patients using multiple daily dose injections in type 1 on insulin pump. But very important is when you do this advanced carbohydrate counting, the patient should be, some intelligence should be there so that they can do the basic math skills because it is the division and additions. And also the patient should be willing to go for regular blood glucose checks after each meal. Only then we can really get to a proper insulin ICR ratio and accordingly give them to match the dose of insulin according to the amount of carbohydrate that they have consumed. And what are the benefits? It regulates the post-meal spikes, helps with weight loss and maintenance, enables the precise insulin and oral anti-diabetic drug dosing, allows for varied food choices while maintaining a good control. And the variants where it is useful is late autoimmune diabetes in adults, maturity onset diabetes of the young, pre-diabetes, and very importantly, gestational diabetes. And how does it help to control the glycemic variability? It reduces the postprandial peaks, increases time in target range because today when we talk of glycemic variability, we generally look at the CGM, and accordingly we manage, because the longer the patient is in controlled blood sugar levels throughout 24 hours, the less will be the chances of development of the macro and microvascular complications. It improves the insulin sensitivity, smoothens the glycemic fluctuation, reducing the blood swings throughout the day. And what are the metrics that are improved, especially in the CGM? You see that the standard deviation is reduced by about 10 to 15 milligram per deciliter. The coefficient of variance is reduced by about 10 to 20%. The mean amplitude of glycemic exertion decreases by 20 to 30 milligram per deciliter. The CGM time in range is increased by 10 to 20%. And what are the studies which confirm that? The Diabetes Care 2020 showed that carb counting reduced glycemic variability by 15% in type 2 DM, and the Journal of Clinical Endocrinology and Metabolism showed it improved time in range by about 12%. So how this carb counting works? It assigns carb values in grams. We can set the daily carb limits based on individual calorie needs, the activity levels of the patient, and also the blood sugar goals that we target. We can track the food intake, monitor the carb counts at each meal, and stay within limits, and snacks. We can adjust the medications by coordinating with the healthcare providers, the dose of insulin and oral antidiabetics. It benefits breakdown. The blood sugar control reduces HbA1c by 1 to 2%, thereby lowering macro and macrovascular complications. It promotes at least an average of 5 to 10% reduction in body weight, and more important, it maintains this weight loss over time. And of course, improve medication efficacy, thereby reducing dose of medication, so it's more economical also for the patient, more affordable. He has to take lesser units of insulin, lesser oral medications. And the food groups by carb counts, we have food containing low carbohydrate counts, we have food with medium, and we have foods having high carbohydrate counts. So a picture speaks more than 1,000 words. So you can see some of the foods which have a high carbohydrate content and some with low carbohydrate content. And coming to the evidence and studies which prove that carb counting has better managed type 2 DM, the ADA studies showed in 2019 that carb counting reduced HbA1c by 1.1 versus 0.4 with traditional counseling. The Journal of Academy of Nutrition and Dietetics showed that it reduced medication use by about 44% and also improved the blood sugar control. The Diabetes, Obesity and Metabolism Journal showed that it resulted in 5.5 kg weight loss versus 1.8 kg with standard therapy. And looking at the trial findings of the Look Ahead trial, carb counting plus lifestyle changes reduced HbA1c by over 0.74% over a period of 10 years. The DPP or Diabetes Prevention Program trial showed carb counting prevented type 2 diabetes progression in 58% of pre-diabetic patients. So that's very important. Somebody wants to maintain his pre-diabetic status by using this carb counting and exercise and diet control. It has shown that it can reduce the progression to the extent of almost 60%. And what are the evidence for carb counting in type 2 diabetes variants? In latent autoimmune diabetes, this diabetes case study of 218 showed that carb counting reduced HbA1c by 0.9% and insulin dose by around 25%. For maturely onset diabetes of the young, the diabetic medicine study 2017 showed that carb counting improved blood sugar control and reduced medication use by 30%. In the pre-diabetes American Journal of Lifestyle Medicine showed reducing the progression to type 2 by over 62% patients. So we had 48 there, now we have 62 in this study itself. And the Journal of Maternal, Fetal and Neonatal Medicine showed you can reduce the birth weight and improve maternal blood glucose control by using carb counting. And the organizational endorsement is that the American Diabetes Association recommends carb counting as a primary meal planning tool The Academy of Nutrition and Dietetics support carb counting for effective blood sugar management. The European Association for the Study of Diabetes endorses carb counting. RSSDI guidelines do recommend carb counting for insulin therapy, particularly for those using mealtime insulin. So what are the takeaways from what I have put together? The carbohydrate counting is an option to provide patients with type 2 diabetes at variance freedom to make choices about their food intake while keeping the post-meal sugar under control. Successful carbohydrate counting depends on reinforcing serving sizes and adequate carbohydrate counts of food eaten and appropriately fitting carbohydrate choices into an individual's meal plan. When teaching advanced carbohydrate counting, one should use the tools given to calculate ICR and SF as starting points. Dose follow-up and modification based on patient need is necessary. Additionally, potential consequences such as inappropriate calorie intake, insulin stacking, insulin resistance and sensitivity, and the effects of high-fat meal should be addressed as they arise. Actually, carb counting is a long and vast topic, and we think if you have to give examples of having the different type of meals, how you calculate this thing, so it becomes we can always discuss this when we sit down and discuss. Thank you.
Thank you so much, Dr. Sanvarala, for that excellent talk on carb counting. I'll now call on Dr. Sanjay Sood to speak on the role of micronutrients' importance in managing insulin resistance and inflammation.
Very good morning to all, and thank you, Dr. De Cruz, for the kind introduction. So straight away I'll go to the topic. Micronutrients are vitamins and minerals needed by the body in very small amounts. However, their impact on a body's health are critical, and deficiency in any of them can cause severe and even life-threatening conditions. They perform a range of functions, including enabling the body to produce enzymes, hormones and other substances needed for normal growth and development. Deficiencies in iron, vitamin A and iodine are the most common around the world, particularly in children and pregnant women. So the recommended dietary allowance of micronutrients, as you can see on the screen, vitamin A, E, D, C, riboflavin, etc. for males, females, age, everything is categorized. And the other minerals like calcium, iron, magnesium, phosphorus, zinc, copper, manganese, selenium, all these are required in small amounts but is essential. So now if we see insulin resistance, it occurs when the body's cells don't respond properly to insulin, and this leads to hyperglycemia. The homeostatic model assessment of insulin resistance, it estimates the insulin resistance based on fasting blood glucose and insulin levels, and it is a useful test. HOMA-IR is a useful test for identifying individuals at risk for developing type 2 diabetes and for monitoring the effectiveness of interventions aimed at improving insulin sensitivity. HOMA-IR can be calculated by the formula with having the fasting glucose in milligram per deciliter multiplied by fasting insulin levels in units per liter divided by 405 as a constant. If it is in millimoles, the value is 22.5. The normal range HOMA-IR score greater than 2.5 is often considered indicative of insulin resistance. If it is less than 2.5 or less than 2, usually you can say that the person is insulin deficient, and if it is more than 2.5, they can be considered to be insulin resistant. Now, inflammation is a vital part of body's defense mechanism working to contain and eliminate threats like bacteria, viruses or physical damage. So, classical signs, as we all know, is the redness, swelling, heat, pain, roll on over color, all these things we have been learning right from our second MD. And acute versus chronic inflammation can be there, and inflammations can be triggered by a wide range of factors including physical injury, infection, autoimmune disorders or exposure to irritants. While inflammation is generally helpful in resolving injuries or infections, it can also cause damage if it persists or is directed at healthy tissues. Chronic inflammation is implicated in many diseases including CVD, cancer and autoimmune disorders. So the markers of inflammation, as you all know, is the CRP, ESR, procalcitonin, cytokines, serum amyloid, fibrinogen, ferritin, calprotectin, etc. So the interconnection between inflammation and insulin resistance. So chronic low-grade inflammation is often associated with obesity, which is a major factor in the development of insulin resistance. This inflammation is triggered by the release of pro-inflammatory cytokines like TNF-alpha and IL-6 from adipose tissues. These cytokines interfere with insulin signaling pathways, making cells less responsive to insulin. Insulin resistance itself can contribute to increased inflammation. Increased blood sugar levels and fat accumulation can trigger inflammation by increasing the reactive oxygen species production and activating inflammatory signaling pathways. The key players as the cytokines like TNF-alpha, IL-6 as well as other inflammatory markers like CRP. So inflammation can affect insulin signaling by interfering with the insulin receptor and its downstreaming signaling pathways, and which leads to the decreased glucose uptake and utilization by cells, resulting in insulin resistance. There is a bidirectional relationship between inflammation and insulin resistance. Insulin resistance worsens inflammation and chronic inflammation exacerbates insulin resistance. So the key micronutrients which will be in focus in my today's talk is magnesium, zinc, chromium, vitamin D, vitamin C, vitamin E and omega-3 fatty acids. These nutrients have been shown to directly or indirectly influence insulin sensitivity and inflammatory pathways. The magnesium helps to maintain proper tyrosine kinase activity at the insulin receptor, which is essential for insulin signaling and glucose uptake. Low magnesium can disrupt this process, leading to impaired insulin action and insulin resistance. So, magnesium deficiency can trigger chronic systemic inflammation too, which can further exacerbate the insulin resistance as it is interconnected. So supplementation studies have shown and suggest that magnesium supplementation can improve insulin sensitivity, particularly in individuals with type 2 diabetes and decreased serum magnesium levels. High dietary magnesium intake has been linked to reduced risk of insulin resistance, especially in overweight and obese individuals. So magnesium-rich foods are the soy products, legumes and seeds, nuts like almonds, cashews, peanuts and peanut butter, whole grain breads and cereals, brown rice, fruits like bananas. They are rich in magnesium. Vegetables, particularly dark green leafy vegetables, dried beans, etc. And 8 drinks that are surprisingly high in magnesium. Mineral water. Even mineral water, it contains added magnesium. Coconut water, plant-based milk, blackstrap molasses, green smoothies, coffee. So that is why there are a lot of trials and studies which say that taking coffee or drinking coffee can reduce insulin resistance and can bring down blood sugar levels. Without sugar, definitely black coffee. I am talking about herbal teas or the green tea. Now zinc is another key component of the insulin hexamer, the form in which insulin is stored in the pancreas. It also directly stimulates insulin action by phosphorylating the beta subunit of the insulin receptor, which activates the insulin signaling pathways and promotes glucose intake. So zinc deficiency can lead to reduced insulin receptor binding and impaired insulin signaling, resulting in the increased insulin sensitivity. Studies have shown that zinc supplementation can improve glycemic control, especially in individuals with diabetes. Stimulation of insulin receptor phosphorylation and inhibition of GSK3 beta. This helps. Zinc transporters, particularly ZNT8, are crucial for zinc storage and function in pancreatic beta cells. The oxidative stress is the zinc is an antioxidant and plays a role in reducing oxidative stress, which is a hallmark for diabetes. And zinc deficiency can lead to increased inflammation, and zinc supplementation may help reduce it. Now chromium. So chromium may increase the number of insulin receptors, and chromium could also enhance the binding of insulin to receptors, further improving the insulin's effectiveness. Potential mechanism is through the chromodulin. Some studies suggest that chromium binds to a low molecular weight chromium binding substance called chromodulin, which may then bind to and activate the insulin receptor, promoting insulin action. In vitro studies have shown that chromium supplementation can improve insulin sensitivity by enhancing insulin receptor signaling, though this has not been fully demonstrated in many living organisms. Now, iodine, by regulating oxidative status, iodine is associated with changes in insulin sensitivity or metabolism. Chronic inflammatory condition paves the way for the development of metabolic disorders. Iodine has well-known anti-inflammatory and immunomodulatory effects and is an essential mineral that is supplied by the diet supplements and has anti-inflammatory, antioxidant, antiproliferative and differentiating agent. Now, vitamin D, there are loads of data about vitamin D that it may enhance insulin receptor expression and improve the ability of insulin to act on target tissues. And a lot of studies are there which have suggested that vitamin D supplementation could be a low cost and effective way to reduce insulin resistance and improve diabetes outcomes. Vitamin C, we all know is antioxidant, and by combating oxidative stress, vitamin C can help reduce inflammation throughout the body. Vitamin E also, there are a lot of data and studies which have shown. One that was published quite recently in the Diabetes and Metabolic Syndrome and Obesity in last year, April only. So it showed one study that serum vitamin E levels are lower in type 2 diabetic patients than in healthy populations, and vitamin E is an independent influencing factor for HOMA-IR in type 2 diabetes patients. The risk of insulin resistance gradually increases in type 2 diabetic patients as serum vitamin E levels decrease, and so vitamin E is a risk factor for insulin resistance if the levels are low. Omega-3 fatty acids also, there are a lot of evidences which show that omega-3 can help lower triglyceride levels and improve the ratio of different types of cholesterol, which can also indirectly contribute to better insulin sensitivity, and increasing the irisin levels, because increase in irisin levels is a protein that plays a role in improving insulin sensitivity and glucose metabolism, and omega-3 fatty acids help to do it. So the synergistic effect of micronutrients, often they work in tandem rather than isolation. For instance, magnesium and vitamin D synergistically influence insulin signaling. A well-balanced diet that includes a variety of nutrients enhances metabolic health more effectively than high doses of a single supplement. Deficiencies can arise from poor diet, chronic illness or malabsorption. These deficiencies exacerbate insulin resistance and promote inflammation. Data from research studies explains the clinical significance of identifying and correcting such deficiencies. Certain groups are more prone to micronutrient deficiencies and thus more vulnerable to insulin resistance and inflammation. These includes the older adults, individuals with obesity, and those with limited access to nutrient-dense foods. Screening and targeted interventions are essential. So we should focus more on such groups. Numerous clinical trials and meta-analyses demonstrate the benefits of micronutrient supplementation in improving insulin sensitivity and reducing inflammation. Supplementation may be necessary in certain cases, particularly when deficiencies are clinically diagnosed. However, this must be done carefully to avoid overdosing or negative interactions. So rather than relying solely on supplements, emphasis should be on whole food diet rich micronutrients and healthy dietary patterns such as the Mediterranean and DASH diets, which are associated with lower inflammation and better insulin control. Yeah, it's the last one. And lifestyle modification integration. Nutrition works best when integrated with other lifestyle practices, because regular physical activity, adequate sleep and stress reduction techniques like mindfulness for a comprehensive approach to metabolic health. So from a public health perspective also, we should add these food fortification, which will have a broad impact. And the take-home message is that micronutrients are essential in managing insulin resistance and inflammation. Balanced diets are foundational and prevention is more effective than treatment. So these were the references. Thank you very much.
Thank you, Dr. Sood. And now I'll call on Dr. Ajay Biswas. He will be speaking on gut microbiota connections, how nutrition impacts gut health and metabolism.
Warm welcome to everyone. I understand we all are essentially involved in clinical care, and whatever microbiological topic we keep on talking, this gut microbiota and ancillary discussion is unfortunately deals essentially a huge chunk of basic science which is beyond a clinician's context. So I have slightly modified the discussion topic that a clinician's perspective, how as a clinician we are looking into the context. Now essentially, when we started our medical journey, way back around 30 years back in 90s, microbiology was essentially identifying one single organism which is causing some disease. So we had chapters on typhoid, we had chapters on pneumonia, we had chapters on staph, strepto, blah 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 kind of thing. And identification was essentially aerobic culture and characterization of an microbiome, the microbiological organism depending upon its traits. Now from that point of time, down the line, last 30 years, we have seen a sea change. What is the essential change? From microbial culture, we have moved on to genetics, we have gone to proteomics, and newer technology like next generation gene sequencing have taken place. And it has changed it completely changed the world, and now we can do more extensive studies on anaerobic organisms as well, which was otherwise very restricted during our days. And from a single species, now we are talking about an ecosystem. Newer words coming up, newer jargons coming up, and we are not only talking about a primary effect of food or primary component of nutrition, but also the impact of its metabolites. Because once you are considering a huge wave full of microorganisms which will be taking up the nutrients, will be producing the metabolites, which will again in turn play the role of signal transduction modulation pathways, and it will be modulating hepatic glucose production, it will be modulating other things, and there will be a huge cascade of changes, not only metabolic dysfunction or dysregulation, but also immune pathways is also get involved. So interaction of cellular signaling that have significantly changed our understanding. At the same time, it has opened up newer treatment opportunities. For example, way back in 30 years back, if someone used to abuse someone by saying, I will curse you that you will be eating the shit, that was a curse. Standing in 2025, we are coming up with the data of RCT where we are giving people fecal microbiota as a transplant, and otherwise not manageable entities like obsessive compulsive disorders and other entities. Now we are trying to find out a solution through this route. You might be asking why I have written the last point, the impact of COVID research. Yes, COVID had many negative impact, but at the same time it challenged our capacity building ability. Because RT-PCR was not enough, people went on doing CVNet and other things. The same device could be used for next generation gene sequencing. So cartridge based next generation gene sequencing have become quite affordable. From one kit costing 1 lakh rupee to test one sample, now it has come down to almost 3,000 to 4,000 rupees to test one stool sample for the microbiome profile. So this is the extent of cost reduction courtesy the COVID pandemic. In this talk, probably you won't find much to note. It will be more of a primer, more of an essential note as a beginner. I consider myself as a beginner in this world of microbiotas. Biomarker sequencing we have talked. Many new jargons have come up over the last 10 years, like metagenomics, metatranscriptomics, metaproteomics, metabolomics, and definitely we are now having integration of them. And these are the huge list of jargon starting from holobiont, metabolome. Anyone can take the PowerPoint. I have given already to the thing. You can all share it. And this is from NEJM paper, 2016 paper, which is a free to download. I can share it. Anyone can text to Didi. I'll share with Didi and you can take the NEJM paper from Didi. So no need to write down things. Absolutely basic thing. So essentially what we mean by the gut microbiota and its implication. It is essentially a complex ecosystem of symbiotic bacteria. They stay in our distal gut and they significantly contribute in our metabolism through production of those clinically significant intestinal metabolites. Now as we have moved ahead, we have identified how they are influenced by our dietary pattern. Whenever you go to any diabetes discussion, our discussion begins that Indian diet is protein poor, therefore Indians derive much from carbs. And we keep cursing our community, wish they could have some more protein. But if I ask you, আমার বাচ্চাটা কেবলমাত্র চিকেন খায়, ভাত, আলু, সবজি কিচ্ছু খায় না, আর আমার বাচ্চাটা সপ্তাহে একদিন টয়লেটে যায়, রোজ বাবেলও ওপেন করে না, do you think we are promoting good health by just selectively encouraging protein? We are asking for soya protein, we are asking from whatever alternative versions of protein. We are talking about in length about gluten-free diet, but at the same time we are not talking about our natural diet pattern that we've been practicing over last 50 years. If I ask anyone, had there been any diabetologist in 90s? No. Why? Why diabetes was not there? I am not asking about the clinical boom. I am not asking about the lifestyle changes. কিন্তু 84তে ওয়ার্ল্ড কাপ জেতার আগে আমরা কি কোক পেপসি খেতে শিখেছিলাম? প্রবাবলি নয়। তার আগে কি আমরা পটাটো চিপস খেতে শিখেছিলাম? তার আগেও কিন্তু বোধহয় শিখিনি। আলুর পরোটা খেয়ে বা আলুর তরকারি আর রুটি খেয়ে কিন্তু কারোর সুগার হয়নি এত। বোধহয় ট্রান্সফ্যাট খেতে আরম্ভ করার পর আর হোয়াটসঅ্যাপ নির্ভর মানুষ হয়ে যাওয়ার পর we have all come into things. So probably this topic is more of an introspection than of a single point solution. We all know these things, the diet components that we all know, how it affects the composition of microbiota. The most important thing is, depending upon the composition of microbiota, your metabolites, they change. Again, depending upon the metabolites, composition of microbiota changes. So if you look into this thing, please remember this transaction, this in-between point, this is essentially a bidirectional thing, not a single directional thing. And that is essentially what I would like to convey over the next, say, 5 minutes. We'll be talking about food. If we don't give food, if we ask someone to fast, how it affects? Well, it can have significant effect on gut microbiota. It promotes production of beneficial short-chain fatty acids like butyrate, which is not only a major energy source for the gut cells, but also reduce the circulating lipopolysaccharides. Is it time?
2 minutes.
So similarly, it reduces inflammation and therefore it also reduces many ancillary entities. If we just have a very quick run through with the Indian diet pattern, the North Indian diet, we all talk about adaptation, requiring to adjust with the lifestyle that we are exposed to. Now it is characterized by wheat-based food, legumes, and significantly influences the gut microbiota by increasing abundance of prevotella, which helps carbohydrate metabolism and also enriches with complex polysaccharide degradation. At the same time, if we look for the South Indian diet, it tends to have higher amount of bacteroids and ruminococcus associated with better protein and fat digestion. In Western Indian diet, we have got more probiotics, less gut inflammation, and the most important part of our interest, the Eastern India, we have got bamboo shoots, we have got fish, we have got what not in our diet. How it translates? It's high in lactic acid fermenters, enhancing absorption. It increases immune response, not necessarily that is always good. That is also associated with inflammatory arthropathy, but at the same time, it has got potential for anti-cancer and osteoporosis prevention. Yes, multiple publications, multiple references will just run through that fish protein being identified as anti-cancer things and osteoporosis prevention through consumption of fish-based meal being recommended. Regular consumption of sugary drinks, Coke, Pepsi, we all know. Now these days we don't have the dairy thing, we use the ice creams. Once again, dysbiosis, metabolic dysfunction, impaired gut healing, we all know. We all know the composition of gut microbiota and GI health. Now if we look for the soya protein, that is also very important. Bifidobacterium, Lactobacillus, Streptococcus, they are up titrated, and Clostridia, Escherichia coli, they are down titrated. Now, depending upon when you are taking, how you are taking, that also implements the things. I will end up by just 2 slides. We are all stressed. Chronic, unpredictable, mild stress. Well, that can disrupt the gut health. And we are finding fish proteins as potential solution for chronic stress. Now, potential treatment opportunity for the functional bowel disease and chronic stress related issues. Last one. সকালবেলা বাঙালি দার্জিলিং চায়ের অ্যাডিকশন। চা ভালো না কফি ভালো? যদি শো অফ হ্যান্ড বলি টাইম বেরিয়ে যাবে, তাই করছি না, করবো ভেবেছিলাম। Now, epidemiological studies have long shown association of tea, which contains polyphenols, having significant metabolic benefits. Now, it has shown these large molecules, these are essentially high molecular weight thing, they get fermented in the distal colon and they produce significant amount of small chain fatty acid producers, and that translates into less anti-inflammatory properties, BP lowering, and also improves platelet aggregation, that prevents platelet aggregation. So, you might be asking, তাহলে কফি নয় কেন? আমি কফি পছন্দ করি। Well, there are some benefits of the coffee as well. It increases the gut motility provided you are having it less than 4 cups a day. And the last line that I was started with, what is FMT? Fecal microbiome transplantation. And the focus study that is looking for, once again, fecal microbiota being tried in a RCT setting for obsessive compulsive disorder. So from brain to gut, we all been talking about how brain-gut axis controls our gut motility, our satiety. Now should we call it gut-brain axis, gut-cardiac axis, gut-lung axis? So probably we don't know a Akhil Brahmande, which one is the ultimate nucleus, no one knows. But probably gut microbiota contains more number of cellular elements than any single organ. So probably time has come to recognize this as a new organ. And with this cup of morning tea, thank you everyone for patient hearing.
Thank you so much, Dr. Ajay. And with that excellent talk, I'll now request our chairperson, Dr. Harish Darla, endocrinologist from Mysore, Dr. Srihari Kulkarni, if he is here, and Dr. Shilpa Agarwal. Please come on the stage.
Can I request all the speakers to come on the stage, please? So, nutrition per se is one day CME, and I'm sure most of them have covered their topic very well within 10 minutes with all time constraints. Any questions from the floor? Yeah, one. Can I have a mic there, please?
Mine is not a question, it is just a comment that either be it coffee or be it tea, we should also educate the public how to drink coffee and tea. We are not drinking tea, we are drinking kadha, we are drinking kulhad chai, we are drinking tandoori chai. The real tree, how it is brewed to get gut microbiota benefit, and how the coffee should be brewed, hardly 2% people they use that technique. So that is very important.
Thank you, sir.
Sir, you will be really happy to know that probably tea is only one thing which has got a reference. Royal Chemical Society published a monograph, how to harness the alkaloids of tea, preparing the tea, that was the paper. Royal Chemical Society recommendation of how to prepare tea in the British India.
But how many people follow that procedure? That is the main thing.
So when we see patients not following your own advice for taking medication, so having tea brewing and coffee brewing is too far for them. Yeah. So any more questions from the floor?
Thank you, sir. My question is for all the speakers. How long can we delay pharmacological intervention when we are following nutritional interventions? what should be the threshold when we should?
This is regarding diabetes, are you asking?
Yeah.
Anybody wants to take that question?
Let me. Let me tell you about the wonderful trial called direct trial. So there was dietary intervention just for the initial 1 to 2 months in the form of restricted calories ranging from 827 to 853 calories. And the patients were recruited whose duration of diabetes was less than 6 years. They also had hypertension, and all the medicines were discontinued at the start of the trial because the patients were put on a restricted calorie diet, which continued only for 1 to 2 months, and then later normal diet was reintroduced in a stepwise manner. But these patients were followed up. After 1 year, it was seen the patients who could lose more than 15 kilograms of body weight, 84% of them were at remission for diabetes, which helped us to coin a new term, post-diabetes, and the results were reconfirmed at the end of 2 years. So the intervention period remained the same, only initial 1 to 2 months, but the benefits were still there, maybe somewhat reduced, but at the end of 2 years, 3 years. So this, based on this direct trial, now NHS at UK offers this dietary intervention initially to the patients whose duration of diabetes is less than 6 years. So you can jolly well, if the patients are motivated, and you will find a lot of talk shows on reversal of diabetes. So this is, so maybe some of these patients will have diabetes again, but maybe, as happens with bariatric surgery, if there is weight regain, maybe diabetes will return, but the dose of anti-diabetic agents probably will get reduced, and that benefit may remain there for the lifetime.
There will be a couple of points here.
Yeah,
Number one, what we are trying to treat. Am I glucocentric? Are we still trying to lower HbA1c and fasting sugar and BP sugar? Probably no. In 2025, I am not trying that. If my patient has got microalbuminuria, I am trying to protect the kidneys. Even if the patient is euglycemic, I am supposed to offer the benefit of newer therapies like SGLT2 inhibitors. Our role is not to promote sales of molecules, but at the same time, we should incorporate the advancement of science in our day-to-day practice. In an urban setting or in a rural setting, 90% of our patients, they consider, I had diabetes, I took medicine, I had diet, I had some compliance, and after that my diabetes was cured. Right? কি বলেন না মা বউও দেখতো ওই খাবারটা কম দিত আমাকে একটু হাঁটতে হাঁটতে বলতো আমি ভালোই ছিলাম I never crossed 200. I don't think this audience of patients whom we serve, 90% of them can be motivated to a stringent diet to lose 15% of body weight, forget the 5% body weight. Second thing, if your focus is end organ protection, please individualize the patient. For those who can afford glucose monitoring, those who can really sincere enough, educated enough, young, not having comorbidities, probably we can try. Otherwise, even if you write the medication, even if you deliver anything, once the glucose control is achieved over next 3 or 4 or whatever few weeks, he will automatically discontinue things and he will continue the lifestyle modification, and people will say, "I'm to prochur teso khai tale kombe na keno." Can I come across with a fun?
We are running short of time. I think we have a next session to go.
Yeah.
And there is a good debate tomorrow, sir, regarding remission and misleading concept. So I am talking misleading concept in remission, so which I am going to counter few things what they have told. So I think any more questions? We'll take the last question now. So that the next session can start, please.
If the patient is having the antipsychotic drugs, so
Just
what is
can
your
you take-
opinion about the Hi, this is dietitian Anindita. I'm a consultant dietitian. Just asking the questions. When the patient is having the antipsychotic drugs, so what is your opinion about the coffee intake and how much they can take the anxiety patients and depression patients and something like that?
See, recommendation should be individualized. Anyone having resting tachycardia and having high amount of coffee consumption, I will not be recommending it.
So how
Anyone
much?
not more than 4 cups. That is a standard recommendation as normal coffee consumption.
1 cup is 5 grams coffee.
Yeah.
And another question is, sir, anybody can ask. My question is that if the patient is having the ribosas or Monjaro for the weight reductions or semaglutide, so the patient is asking me, ma'am, how long doctors will provide that medications? This is lifelong procedures or something like that. Because once we are just reducing the weight loss, patient's weight loss, then after weight loss, I just bring my
If you
patients.
discontinue the thing,
Yeah.
probably it will start gaining the weight,
Yeah.
and probably that remains around 12% reduction. That is the cutoff one can achieve.
Okay.
But
Thanks.
it keeps on gaining weight. Once you discontinue Monjaro, once again it starts gaining weight.
Okay. Thank you.
So I think there's a request for last question. And after that, if there's any more questions, we can take it from the speakers later, please. Thank you.
Hello. Very good morning. I am dietitian Shobhit Chakraborty. So my question is basically to respected speakers. So patient used to come to us and we sometimes recommend this keto diet or intermittent fasting sometime. So after recommending this, we are also bounding it to 1 month or 20 days or something like that. So after following this, the patient are getting good report and good result. So after that, they are trying to continuing for long time. Is it a good option, and what is the intervention in medical intervention, like the doses will be reduced or maybe altered? What are the interventions from your side?
See, there is every possibility which I have discussed during my presentation that once you are able to cut down your body weight substantially, your insulin sensitivity improves. So there is every possibility the number of medicines may actually come down, and it depends on the motivation of the patient. These are excellent agents in the short term, but in the long run it is very difficult to continue with the keto diet. Most of the patients, once they quit, they start regaining body weight. So and since it is a high fat diet, which I showed you, almost 65 to 70% fats, so that can you actually increase the risk of atherosclerotic cardiovascular disease especially in the elderly who otherwise have all the risk factors of such things.
And that's the reason no diet is recommended as such in ADA recommendations. There is no specific one diet that has been recommended.
Right.
The moderation and balance has been recommended.
For short term, keto diet is fine.
Basically,
Again, individualized.
we are recommending a holistic diet and
But the option of fat should be customized. As it is 70% fat, people are taking more of saturated fat, then end up with many problems.
So
how many of them can afford avocado or that coffee with fat? That is the option. Fat option of the fat should be
option of fat.
important.
Thank you.
So, thank you so much for your patience here. Thank you.